Hello and welcome to this session of the Center for Podiatry Education. In this session, I'd like to talk about this issue of fall risk evaluation. That is to say, the evaluation of our elderly patients for risks of falls and what the role is of the podiatric physician. We hear much about this, and certainly the podiatric physician is not in a position, as are other healthcare providers, really, to do a total evaluation of the patient who is at risk. But we are charged with caring for an awful lot of older patients. We know that falls are common in these patients, and I think it's helpful to evaluate patients yearly for risk for falls, get a note back to the primary care physician or geriatric specialist or whoever's responsible for the overall health of that patient. Obviously, this is something that is satisfying and that it helps you to participate in the overall health of our patients, the overall care of our patients. You might call it value added, if you will. And I think that should be the primary motivation for evaluating patients for this risk. The World Health Organization defines a fall as an event that results in a person coming to rest inadvertently on the ground or floor or other lower level. We know the risks of falls increase exponentially with aging. The majority of falls that do occur in older patients occur at their home. Women have a higher incidence of falls than do men. And in older patients, 40% of all injury-related deaths are actually the results of a fall. The frequency of falls in the elderly patients are quite common. Over the age of 65, anywhere from 28 to 35% of patients sustain a fall every year. Over the age of 70, over 1/3, up to 40% of patients sustain a fall every year. Patients who are in nursing homes tend to fall more frequently than community-dwelling elderly, which makes sense because you would assume that patients in a nursing home are more frail, likely have more comorbid conditions, are less able to take care of themselves. If you look at people living in a long-term facility, anywhere from 1/3 to 50% of individuals living in long-term facilities sustain a fall every year, and about 40% of these patients sustain more than one fall per year. If we look at the consequences of falling and why it is that we want to take a look at our older patients for risk of falling, this accounts for almost 1/3 of mild to severe injuries in the elderly. Overall, if you look at any emergency department, about 10 to 15% of visits are due to falls in elderly patients, and all injury-related hospitalizations of the elderly, about half of them are due to falls over the age of 65. These are not without consequences. Many elderly patients who fall remain in the hospital greater than 3 weeks. Some are going to remain in the hospital for the remainder of their lives and eventually die either in a hospital or a rehabilitation center. 20% of patients who fall die within the first year of their fall. And we've seen this specially develop of orthogeriatrics, and we've discussed this in a different session of podiatry, the Center for Podiatric Education. But it's interesting that with all the elderly patients that we see in our profession, we have yet to develop a specialty group or interest just in podiatric geriatrics. Those who do fall frequently sustain a change in lifestyle that's commonly referred to as post-fall syndrome. They have a fear of falling. They have increased dependency on others once they take that initial fall. Because of the fall and the perceived risk this imposes on their lives, these patients suffer from depression, confusion. They tend to be immobilized either from injuries due to the fall or self-induced mobilization. They tend to decrease their activity level, and overall there's definitely a loss of autonomy that occurs in patients' lives once they sustain that first fall. We can look at graphic materials such as this, looking at fatal falls by age and gender, and we could see that obviously the fall rates that result in death increase over time. The older the patient, the more likely they are to sustain a death with their fall. And again, we see the death rate is actually higher in men than in women, although women tend to, again, sustain more falls than do men. So why get involved? Well, again, we just want to look at the consequences of falling. And there's this loss of independence. There is pain as a result of injuries. There's the trauma and the surgery associated with this. There is the fear of falling, the loss of confidence in daily activity living, and as a result of that, these patients tend to restrict their activity level. They don't get out very much, they don't get around very much, and this is a serious problem. So what is your job as a podiatric physician? I would argue that your first job is to incorporate an annual fall risk evaluation. You may say, well, that's not my job, Mon. Well, if it's not your job, the question is, whose job is it? Do you believe that primary care physicians have incorporated this assessment as a routine part of their practice? I'm sure there are some that do, but there are many, I'm sure, who do not. And just as the podiatrist is frequently the first individual to detect the presence of disorders such as peripheral vascular disease, such as subtle manifestations of a neurologic process, this is an area where you can make a definite contribution. And I think doing things like this makes your life meaningful. It makes your practice meaningful. And you may or may not make some additional income doing this, but this is what really being a doctor is all about. So you want to identify these patients who are at higher risk to the primary care physician. You want to incorporate into the medical records, into your progress note, the fact that you have performed some assessment regarding fall propensity. And obviously, when you're treating patients that you're going to immobilize in some fashion, that you're treating for ulcers, perhaps you're planning on doing some surgical procedure, treating them for osteomyelitis, putting them in a cast for a fracture, then you have to stand back for a second and look up from that foot and look at that patient and saying, how is this going to impact on their life generally? Or am I placing this patient at increased risk for a fall? And if I am, what am I going to do about this? And this will require some questioning and assessments that you might normally not ask or inquire about. You want to provide appropriate interventions. There are things that you can do as a podiatrist to decrease the risk of falls. You want to provide the patient and family with education regarding risk assessment. This includes sitting down, talking to the family and the patient about the foot being wrapped up, treating that ulcer, or post-operatively wearing that surgical shoe or whatever, and talk about shoes and clutter on the floors and adequate lighting in the home and issues such as that. Or you can take the position that unfortunately some of our colleagues have taken and use this as an opportunity to find excuses to sell at-risk patients a variety of products for money. And most of these, such as socks and special shoes and special braces and unproven therapies, really have very little, if any, literature to support their use. And we see these therapies and products endorsed by and advocated by the management people, the people that are advocating or teaching how to make more money in practice, the practice management people. And really, we don't see much of this advocated in academic circles. And I do think we play a role in risk prevention and fall prevention, but it's a limited risk. So how does the podiatrist play a role? Well, if you look at the data that's available, we know that abnormalities in balance and abnormality in gait are the first or second most common and predictive risk factor predisposing to fractures in the elderly. So we certainly can take the time to do some simple things to evaluate the gait and the balance of those patients who are coming to see us, even if it's just for routine foot care yearly. If it means that you're going to tack on an office visit with a 25 modifier, then do it. If that's what it's going to take to get you to participate in this, then do it. That should not be the motivation. It shouldn't be the reason. But certainly if you're going to take the time to be a doctor and not just a technician, then indeed you ought to probably bill for that. But that should absolutely not be your main motivation. We know that we can assess these patients' gait and balance because that increased fracture risk is associated with falls, reduced activity level. There's no reason we can't inquire from the family or the patient regarding their fall history, regarding their activity level, and assessing that patient generally and encouraging them to participate more in physical activity. We want to look at their physical limitations. We want to look at the presence of any osteopenia or osteoporosis and perhaps intervene as necessary. So your job is to incorporate an annual fall risk and again evaluate patients for these risk factors. Looking at the elderly patient, we know that with aging there's increased risk of falls. This is due to both intrinsic and extrinsic factors. And while we're not going to likely go to the home of our patients and inspect them, there's no reason why we can't talk about the fact, particularly if the patient is post-op or treating them for some pathology that's going to tie up their foot, wrap up their foot, and talk to the family about proper illumination at home, making sure that the floors are clean, making sure that chairs are readily available, that maybe provisions are made for easier access to the bathroom and so forth. We also know that many of our patients are taking medications that can have effects on neural function, maybe sedatives, maybe medications taken for sleep. We have to be careful in our patients who are elderly prescribing analgesics because we know that neuropsychiatric side effects can be associated with these. We may have patients who are being treated for disorders with which peripheral neuropathy is associated. So over time, these chronic diseases, the increased use of medications, the fact that these patients are more frail and not as mobile, these things all play a role in increasing the risk of falls in these patients. Looking at risk factors for falls in general. As we've already noted, increased age is associated with increased risk of falling. We may look at our patients for evidence of cognitive impairment. Again, we know that women have a higher incidence of falls. Past history of falls may be important. There's no reason why we cannot perform a proper neurologic and biomechanical examination and look for evidence of lower extremity weakness. We can look for balance problems. If necessary, we can assess for vitamin D deficiency. We can help to relieve pain that may alter a patient's gait and alter them to such an extent that it may predispose them to falling. We certainly can do assessments for common neurologic disorders. We want to evaluate patients for the effects of stroke. And again, there are things we can do both non-operatively and operatively for many of these patients, and intervening for painful arthritis. So if you look at the list of common risk factors for falls, it's clear that we can certainly make inquiries, we can certainly assess patients for these problems, and oftentimes we can provide some interventions that will lower the risk of these problems. Now, if you look at the risk factors advocated for bracing by the practice management people, they've kind of simplified all of this, and they look for a history of prior falling, inability to cut toenails, or the presence of a foot ulcer or a wound. And I'm certain that common sense would dictate to all of us that these factors, particularly inability to cut toenails and presence of a foot ulcer or wound, will impact on someone's gait. But whether or not these actually contribute to an increased risk of falls, I think is questionable. Looking at the etiology of falls, number one are accidents, and frequently these are environmentally related in the patient's home. But beyond that, number one is gait and balance and weakness. So that here again, as podiatric physicians, there is nothing stopping us from assessing that patient's gait, assessing their balance, and assessing them for the presence of any lower extremity weakness, and making appropriate recommendations, appropriate interventions. Some of these things are really not within the province of a podiatrist, but we can still ask questions and assess them for history of things such as orthostatic hypotension, fainting, and again, looking at some of the medications which patients are taking. For example, they may be on an antihypertensive that is simply dropping their pressure too low. Looking at these risk factors, again, we know that lower extremity weakness is a factor, abnormalities in gait, abnormalities in balance. The patients that come to see us using gait-assistive devices such as canes, patients who have altered gait due to osteoarthritis of the hip, or the knee, or the ankle, or the foot. All of these things play a role in falls, and I would argue strenuously that there is simply no reason why you, as a podiatric physician, cannot assess patients for the majority of these issues and recommend appropriate interventions back to the primary care physician. So the podiatric physician can evaluate the patient several ways. The first is, of course, taking a history. And you may do nothing more than take a history and tell the family and the patient, I think you are at some risk for falls, and get that note back to the primary care physician. You may use various scales, and there are a number of scales and evaluation systems that are available for assessing patients for falls. You want to do a brief examination of gait and balance in the office. It's not all that difficult, and there's no reason why you cannot incorporate a mini neurologic examination, and again, this will be discussed elsewhere in a separate lecture in the within the Center for Podiatric Education. So there are a number of these fall risk assessment scales available to any podiatric physician, and there's literally dozens of them. The Morse fall scale is one that's commonly utilized, and again, we've discussed this elsewhere on this website. So you can assign points. Is there a history of falls in the last 3 months? Does the patient have a secondary diagnosis with which falls are known to be associated? Is the patient using an ambulatory aid, or do they require the assistance of the furniture, for example, to get up from a chair, or get up from the couch? Patients who are dragging around oxygen or intravenous catheters or urinary tract catheters. You want to evaluate their gait and determine whether their gait is normal, is it weak, is it impaired, and then their mental status. Do they seem to have psychological or mental issues such that you would anticipate a higher risk for falls? This is another example of a different scale. This one's used at Johns Hopkins, and you can see again points are assessed for various levels of risk. For example, greater than 80 years old is 3 points. Have they had a fall within 6 months prior to admission to the hospital? Again, looking at urine and bowel habits, the frequency and presence of any urgency, looking at medications the patient is taking that can affect their balance or ability to perceive and interact with their environment. Are they using any type of equipment that will interfere with normal gait? Do they require a gait aid? Do they have visual impairment? Do they have cognitive impairment? So you can use any of these scales if you choose to do so, this is certainly going to be helpful. Yet another scale, this one from Memorial Sloan Kettering Cancer Center. Here again, looking at history of falls. Does the patient need help transferring to the toilet or commode? Do they need help going from bed to chair? Do they have visual or auditory impairment affecting mobility? Is there the presence of a peripheral neuropathy? Do they have gait imbalance? Do they have a hemiparesis? Do they have weakness? Are they on drugs that can affect their gait? So you can make this as simple or as complex as you feel is compatible with your style of practice, but some form of gait assessment and balance assessment and fall risk assessment probably should be incorporated. In my own practice, and I would recommend doing this in your practice, I go with single task performance testing. So I evaluate the patient's history, I look at the medications they're taking, I stand back and look at that patient in general, and I find that single task performance testing is simple, it's reliable, and it takes just a little bit of time. So I'm going to assess that patient going to the chair, getting up from the chair, walking from the chair, and I just make simple notations. Is the patient steady and balanced when they're sitting in the podiatry chair? Is the patient able to stand up from the chair with their arms folded without grabbing the arms and having to stand up with it? Once they stand, do they appear to be steady in narrow stance? You could do modification of other testing and have the patient just stand with their eyes closed and see whether or not they remain steady. You might touch the patient, push them a little bit, and see whether or not they have the ability to recover without difficulty, or does that little bit of a push or nudge make a big difference in their perceived balance. What about when you have the patient stand? You assess their posture, you assess their foot positioning, and then you ask them to walk. Can they start walking without hesitancy? Is there some delay? Is there some extra effort, in your opinion, being rendered just to get the patient to start walking again? Do they clear the foot off the floor when they're walking? Are the steps equal in length between the left and right side, or is there an asymmetry? Do they take continuous regular steps? Do they walk without the need of a walking aid? Can they stand and ambulate with their heels closer together, and are they able to sit and judge distances correctly? The simplest test to do in the office is the get up and go test, and this is done by having the patient get up from the chair, walk 10 feet, stop, turn around, go back to the chair, and sit down. And certainly anyone listening to this presentation is capable of doing this single task evaluation, the get up and go test. And you want to look at, first of all, how they're getting out of the chair. Are they using their arms to stand? If they are, perhaps that's reflective of some weakness in the hip musculature, the thigh musculature. Do they sway or stagger as they get up and walk? Do they take more than 3 steps to turn around? And we're going to look for rather classic abnormalities in gait, which we are going to be discussing in another session of the Center for Podiatric Education. But you're going to look for classic problems such as a waddling gait. Do they have an ataxia due to vestibular dysfunction or sensory dysfunction? Do they have a foot drop? This type of thing. The normals are generally accepted as listed here. The typical normal get up and go test, meaning the patient stands up, walks 10 feet, stops, turns around, goes back to your podiatry chair and sits down, should be done in less than 10 seconds. Less than 20 seconds means the patient is probably okay, but once you start getting greater than 20 seconds, 20 to 29 seconds, they are at increasing risk for falls. And greater than 30 seconds, these patients are at significant risk for falls, and the primary probably needs to be associated notified of that. So when the patient arises from the chair, you want to watch. Do they have difficulty getting up? Do they fall back into the chair? Are they swaying side to side? You want to watch them walk 10 feet, look at their posture, look at the stride length, look at the symmetry of their length. Again, you're going to look at clearance of their foot while walking, their heel strike, their arm swing. Do they have a shuffling or spastic gait, a hemiparetic gait? And again, you want to watch them turn and see whether it requires greater than 3 steps in order for them to turn about. And this will give you a fairly good assessment that the patient is at risk for falls, and again, notify the primary care physician of that. A more time-consuming test, though not that much more, is the chair rise chest, and that's simply asking the patient to get up and down 5 times. And you want to look and see how the patient does that. Can they do that without having to grab the arms of the chair? Can they do that with their arms folded in front of them? And here again, the inability to get up and down 5 times, and the inability to do this is a good predictor for recurrent falling. Another test, which I really don't do all that much, I think it's a little bit more risky, is the forward and backward step test. You have your patient cross their arms on their chest and they step out with one leg as far as they can. See if they can maintain that position on the other leg and then return back to their starting position. This requires a good deal more balance. It is, however, a good predictor of frequent falling and correlates very, very well with balance and mobility. Of course, one can go on to perform a comprehensive risk evaluation, and this includes a comprehensive history, a comprehensive examination, the filling out of various questionnaires and multitask measures. And this generally takes a good deal of time. It involves the evaluation of posterior column function, eye function, vestibular function, examination of the central and peripheral nervous system. And I don't think most podiatrists are going to be completing a more comprehensive risk evaluation, and the simple task assessments and the simple screens are adequate. And I will do these things. I will charge an office visit for this. I will document my evaluation and get that note back to the primary care physician. So you've done your job. You've assessed the patient's risks for falls. So now what do you do? Well, you discuss the findings with the patient, and you discuss the findings with the family. Frequently, I will refer these patients out for gait training or appropriate physical therapy. I will prescribe appropriate gait assistive devices as I see the need to do so. I look at the medications the patients are taking and try not to compound the problem by adding medications that can lower their blood pressure or contribute to their neuropsychiatric issues. I will send a note to the primary care physician. You can typically do this within your progress note. You could pick up the telephone. You could do it by any means of communication. And then there are, of course, appropriate podiatric interventions. You may care for painful lower extremity conditions that are causing an alteration in their gait. You may provide bracing or surgical procedures or footwear for conditions that are unstable. So there are many things that you as a podiatric physician can do other than just making the diagnosis, although frankly I think number one is assessing the patient, making that diagnosis, and alerting the primary care physician to the presence of these abnormalities. You know, when you do this type of thing, I think the primary care physicians get a different sense about you. I think they have a different perspective of you, and they realize that you are a doctor and that you're not there strictly looking at the foot and not looking up at that patient. And I think that's important, and I think it's helpful if you want to talk about practice building. Personally, I would rather practice build by having more referrals from a primary care doctor, knowing that they are comfortable with my general assessment of that patient, rather than selling them or finding excuses to sell them braces and socks and shoes and various devices and therapies that may or may not be effective. When a patient is at risk for falls, I think it's also important to discuss with the patient and their family the environment in which the patient lives. And again, this becomes very important when we are contributing to the potential increased risk of a fall by wrapping up a foot, having the patient use a cam walker or a shoe or a surgical shoe, or place them in a cast when they're post-op, but things that can increase their instability. And so you want to inquire about stairs at home, the presence of rugs at home, the lighting at home, and have the family think about things that they could do to go back to their mom or dad or relatives' home to decrease the likelihood of an incident. We want to encourage appropriate exercise and therapies, and there are a number of interventions that physical therapists and physiatrists and others can provide. And we want to encourage the use of gait-assistive devices. It's surprising how many people will not use a brace, for example, for a drop foot. They will not use a cane. They will not use a walker for whatever their individual reason is. And I think we need to take the time and talk to these patients and explain to them the significant potential risk, even death, from falls, and get them to be more cooperative in the use of their gait-assistive devices. What happens when we refer these patients back to the primary care physician? This is sort of a general schema of how patients are generally evaluated, and we could modify this for the podiatric physician, certainly. But this will include a multifactorial risk assessment in the patients that do have difficulty with balancing, the patients who have had perhaps one fall in the past year. Again, they're going to be evaluated for gait abnormalities, 2 or more falls. Here again, a multifactorial risk assessment. And this may include evaluation of their 8th cranial nerve, their eyes, their peripheral nervous system, central nervous system, spinal cord. We want to keep vitamin D levels adequate, frequently referring these patients for group exercises and all these programs that are available in these extended care facilities and nursing homes and so forth. This can all be helpful, and we can enter these patients into the system to try to prevent falls. Looking at recommendations for fall prevention practice, we can look at the evidence-based medicine associated with this, and we know that vitamin D supplementation in patients living in a nursing home or in the community is important. We know that exercise and balance and strength and gait training are important, and multifactorial risk assessment is important. But all of these factors listed in front of you are critical and should be provided. And again, if you don't want to take the lead for doing this, at least get the patient into the system so that this is provided to them. So how do you know when your work is done? Well, I'm not certain that we necessarily have to go this far and have our elderly patients standing on one leg, balancing a ball on their nose. But we know this, that falls are a significant problem in the elderly. We know that it is associated with significant morbidity and mortality. We know that podiatrists see a number of elderly patients. We know that podiatrists are in an excellent position to evaluate gait and balance and the peripheral nervous system, and we are capable of doing that. And so we want to perhaps consider taking that responsibility, evaluating our patients for risk for falls, and getting them into the system, whether we want to actively participate as treating doctors or get them into places where they will get the appropriate therapies. I think, again, it makes the practice of podiatry and primary care podiatry meaningful, and I thank you for your attention.